Thank you. My name is Mike Hogarth. I'm a faculty in the University of California, and thank you for having me here. And I'm here to kind of give you insight into a project that we've had going on that I think might be of value, and I'm here to ask you that question. So I don't have the clicker set up, but maybe you can come to me later and say, good idea, bad idea, you know. We'll take whatever feedback we can get. One thing I just wanted to quickly comment on was we've had a patient that came to us 150 times in a year, mostly through the emergency department, and actually was a bariatric patient. So this is a consequence of lack of prevention. So, you know, and there are these follow-on problems that happen along with, you know, dialysis-dependent renal failure and that kind of thing. So there's a huge cost. And I have to say, I'm guilty as charged. As a clinician, I don't do enough in prevention, and the system is not set up to allow it, just as you're pointing out. So the other thing I'll mention is, you know, I had an opportunity through a Robert Wood Johnson Foundation grant a few years back to actually visit with Jackie Spear. And she said the University of California provides somewhere on the order of 20% of the care in California. I don't know if that was a little bit of an overstretch, but we need to partner. If that's true, we really need to partner because our system has to change significantly. So I'm here to really talk about clinical data and access to clinical data. I'll just leave you with this quote many of you have probably heard before. If you can't measure it, you can't change it. You know, you can't improve it if you can't really measure things. And so, if you don't know where you are, you're not going to go where you're not going to know where you're going and the outcome. And so, this is really to address that issue. So, I'm going to talk to you about a project that we've had that was funded by, Genesis started in an internally funded project by the UC Office of the President, and then evolved to being funded by PCORI, the Patient-Centered Outcomes Research Institute, which is part of the ACA, and has a time limit to it. Unless re-upped by the Congress in 2019, it disappears. And I don't think I've ever seen anything like that actually be re-upped by the Congress, regardless of party. So I'm not sure what will happen with PCORI, but I think they've done a fabulous job of setting up infrastructure, and I'm here to just tell you about what we've done with their help. And the question here is, if you had access to this query network that I'm going to describe, would it be useful to public health in California? I think it might be, and in what way? And then come talk to us. So the story that I'm going to tell really starts with this UC Rex, which unfortunately I gave it the name. I regret saying it was Research Exchange because it really has a lot more value than just research exchange. But the idea was we realized that the UC was implementing electronic medical records, many of us in advance of the HITECH Act. And I think collectively in the UC, we've spent somewhere on the order of $500 to $600 million implementing that. And I saw everybody implementing clinical data warehouses where data is pushed in for secondary purposes, analytics and that kind of thing, and everybody was doing it by themselves and in different ways. So we decided, how about let's get together? We proposed doing this collectively. So we succeeded in doing that, and we created a system whereby you can query the 5 clinical data repositories in unison for counts, at least in the beginning. And these are the pieces of data that, at least data elements, I guess, that are patient-related, and you can see the total across the UC is 350 million data points. And I can just tell you that we're missing a lot of data. There's a lot more data in the EHR, just in my institution alone. Flow sheet data, which is very important and very useful for inpatient tracking of patients. We have 750 million rows of data just in my institution. So it's a significant amount of data, this just scratching the surface, and it was sort of the beginning of trying to connect. Nobody had connected 5 clinical data warehouses this way with a common infrastructure. And this is the actual query system we can use. and we query across all of the systems. And this is de-identified data. You can't get patient identifiers. This is aggregate queries. And like I said, UC-Rex is for counts for researchers to decide whether the question they have in mind has enough patient data or access to enough patients with that combination of problems to be able to use the data warehouse data for that research. That evolved to applying for a funding for a PCORI clinical data research network. PCORI set these up as networks where you could query in the same fashion. And so we applied under the title Patient-Centered Scalable National Network for Effectiveness Research, or PScanner, and we were funded to continue this work and slightly modify and make this a little bit more valuable and being able to query more data in different ways. So the whole idea here is to bring the questions to the data, not provide data outward. So many of us have become used to having data sets that we provide outward. This requires a little shifting of thinking where how about having people being able to ask questions, even sophisticated questions, of your data without you dispersing the data. So that's the idea. And the same question or query is submitted to all of the nodes in the system, and you will see kind of how we manage that. So it's designed really using a common design, relational database design. Those of you who are used to that, if you're not, it's about tables, columns of data. And so the table names are all the same, the column names are all the same, but most importantly, the data within is harmonized and standardized. So we've coded all the data, and the codes for example, lab results are the same. And so you can query essentially across the system using the same query. And we currently return aggregate or statistical model results. So the query goes out using a portal, and the results come back to the individual who did the query. So who's involved in PScanner? We're in the second phase. The first phase was limited to a smaller number of institutions, accounting for about 14 to 15 million patients or patient records. This is 14 systems and 30 million patient records, but I have to admit 11 million of them are in the VA. The VA has collaborated with us, and this is the national VA database. And you can see that they're pretty comfortable with having questions come to the data. They're not very comfortable with providing data outward. And so I can just tell you that providing data outward is usually a big obstacle and for a variety of reasons. And if you set up a distributed federated query system, you will see, I think, more adoption. It does provide some limitations, but I think you get a significant amount of value right away. And so you see there the UCs, USC, Cedars, and I'm very proud to say that San Mateo Medical Center is also part of our network. So if this works, and the proof that this works is that you'll be able to get good data out of San Mateo compared to some of your other phase ones. So we'll see. I'd be curious to get feedback on that. So here's how PScanner is laid out. Now this is the California. So PScanner, the 14 sites actually include folks outside of California. We did this as a federally funded sort of West Coast centered thing with the VA. But PScanner California is a subset that's significant and accounts for about 14 million patient records in 10 California institutions that vary in size, from very big to some FQHCs in Southern California, and then San Mateo as well. Now, some of you are probably a little worried. Oh my gosh, they're querying patient records, and what does that mean, right? Exactly. So there are multiple controls. Okay, so the key points here. This is a busy slide, but the key point is the stuff is definitely secured. Okay, HIPAA compliant. Only authorized users can issue queries using a secure portal. The queries actually then arrive at a local node where a person who's an approver has to approve those before they're run on the local infrastructure. And the result set has to be approved or can be approved before it goes out. But you can also auto these. So if this is a query that you've seen 100 times before and it's absolutely fine, then okay, I'll make that one an auto-approved query. and the results can go back, okay? So this just basically facilitates the information infrastructure, but it does not sidestep the authorization and the privacy security portions, okay? So hopefully I calm some of those fears a little bit. Some of the opportunities for PScanner, you know, we didn't design this for public health, but it definitely is population health and, you know, ability to track actual practice. So just so you know, this isn't a static data set. We update our individual nodes either daily or weekly across the system, and we do so with the same map data. So this is, I think, probably the highest quality data you're going to get out of most health systems. We kind of have an internal UC joke because once you connect to the data in clinical systems, you then realize what you're really dealing with. And it's not the kind of data you're dealing with. You're very good at collecting high quality data. In general, you go out there, it's very expensive to do so, but you do it and you curate it and you have great data sets. This is raw clinical practice data, so we call that DIRDA right now. So feel free to use that term. So this is DIRDA, but you know, it's not, it's better than zero, and it allows us to improve it. So intended, some of the possible uses, you know, linking EHR data to pharmacy claims to look at unintended use of pharmaceuticals after visit, hospitalizations and outpatient adherence to interventions. You know, opiate and opioid overprescribing is a great use case here as well, and linking that to the death master file, for example, that kind of thing. And so, you know, I mentioned de-identified data, but then I just mentioned linkage. So there's an opportunity to do linkage, but, you know, how could that be done with anonymized data? So there's research being done in our network that I think is groundbreaking, and the individuals responsible for that are standing in the back of the room. They're my colleagues from USC, Daniela Meeker and Jason Doctor, and they are working on privacy-preserving data linkage that you can query. So I'm not an expert in that, so if you have questions, they're the people to talk to. But in essence, the challenge is how do you implement privacy-preserving queries on data that correctly links records across one or more data sets. And many of you have dealt with record linkages. It's not easy. And then to do so such that the query comes in and it's on the same individuals. And I'll show you a graphic that kind of describes that a bit. So this is kind of what we have today in PScanner. We have different individuals and different databases, and we can query across them uniformly. And this is another view, which is an individual who has some of their data perhaps in the EHR, and then some of the data, which we're not very good at capturing social determinants of health in the EHR, I can just tell you that, and we certainly don't do a good job of capturing patient-reported information, which I think is also key in understanding the experience of the patient. That's foreign territory. And so, you know, linking this to things that have that information would be key. But to do so in a privacy-preserving way without having to give people the data set with all the identifiers and have them merge it in one place, which is what we traditionally do. So there are ways to do this. There's actually a paper there, a citation, that you're welcome to. I believe it's open content. I hope it is. And you can download it fully. If not, we'll be around in one of the networking sessions to answer these questions. Here's just some of the methods in terms of record linkage in a privacy-preserving way. There's matching paradigms and also ways of doing advanced cryptographic techniques which allow you to compute on actual encrypted data. Again, I'm not an expert. It's kind of a black box to me, but it seems to work pretty well. All right, so I'm now going to talk about PScanner. Kind of, people that know me know I hate vaporware. And so this isn't vaporware. This actually is here, and it runs. And so these are screen captures that you're going to see. No, we're not showing any patient data. And so this is an on-demand research network. These are slides from Daniela at USC. And again, this is sort of the idea. We have multiple electronic medical records. They vary in type. There's hard work, a lot of hammers, to make that data into this common data model and, more importantly, harmonized data that has been coded and mapped to common standard coding systems and stored in the same way. So I just want to give you one example, a very easy example. People often go, how hard could it be to measure, the average BMI across the health system, or, the average systolic blood pressure, right? Trust me, it's hard, because in one place, they'll store systolic blood pressure is a great example, because it's systolic/diastolic. Or is it systolic in this column and diastolic in that column? Or is it stored as a string, Everybody does it differently. So that's what I mean by kind of making sure we do it all the same. So, and we have that problem. One of my biggest challenges, I still want to get the average BMI of all the inpatients at UC Davis as a running number, just as a, kind of a morbidity index. Still haven't been able to do it. I've been there 20 years, so I'm hoping we can do it this way. But so then we have, they go to their respective clinical data warehouses, and then we have a variety of additional views that we can do. Data quality, care quality, could be public health queries. I could see standard public health queries come this way to the health systems. And I really don't, I'm hopeful that we don't need to have legislation forcing people to do this when it's this easy and we're all on the same team and want the same goals. This should be something health systems should want to do. I believe with value-based purchasing, they will run to this very quickly. Soon enough. Macro's coming. It's a train that I think many of them don't see coming, and it's about to hit many providers. And I think it's actually a good thing. So here's the screen capture of the central portal. So this is a way to query. These are a variety of different queries. They're boxed up as studies. Again, we built this as a research network, and the idea that these are cohorts that we would do analytics on. This could easily be transformed to public health queries in the same way. You do a new request and you create the query request. Here is just some of the information that you would see. You notice there's a requester, a priority, the purpose of use, the level of PHI disclosure, on and on, a lot of metadata associated with these queries, okay? And the date, it should, it's due, if it has to be run right away, the data sets involved, and the purpose. And then again, this is, PScanner's sort of secret sauce, if you will, is the ability to obtain an analysis result that combines data across sites without requiring transfer of row-level data. So again, those of you who don't believe it, we have people in the back who can talk to you about that. Because when I first heard it, I wasn't a believer. I thought this is, no way. And sure enough, there are ways to do this. So it is definitely being done, and there's research in this network being done to make this actually happen. And we have the portal actually doing it. So here's selecting parameters in the portal, the library, the type of statistical method, in this case, linear regression. So again, this idea that you can essentially line up the computation you want, as sophisticated as it might be, as a plan that you then send to the system without actually having to get the data yourself. So, and here's actually output from logistic regression on a variety of variables. So you can see that right there, and then you have a single model across 3 systems that's actually been graphed. Here's a screenshot of a system that's running at USC, which is one of the PScanner nodes. They put a dashboard system on top of their PScanner. So this is since this is a common data model, you can put, it allows one to have software that's been designed to access those common data elements and common tables, and then do this kind of maneuver. So they do it. We could easily implement the same thing at my institution. Because this plugs into OMOP. There's actually another tool called Achilles, which allows for data profiling. And through that tool, I discovered some interesting anomalies in our UC Davis data. I hope nobody from UC Davis is here except for Alyssa, who's a friend. This is not anything bad. This is being transparent. We had 23,000 people die January 1st, 1980, apparently. People who really know me know why I'm interested in that. That's an anomaly that will never be cured or changed. And so if you have a statistic that goes across that period of time that involves mortality, there's a problem. And you just need to be aware of that. So there's a sort of data anomaly view that you need to have of your data. Again, like I said, this is DIRTA, not data. And you're used to clean data, at least I think most of the time. You work very hard to get very good clean data, but in this environment it's DIRTA. So, but it's immediate DIRTA, so it's fast. Here's a population health metric, a bunch of different counts, and then drill down on children's health, for example, here. And again, these are from USC Daniela, so feel free to talk to her about these at the networking session. And I just want to mention, I have 5 minutes. This is the last slide. I did want to also kind of sort of provide kudos to California Department of Public Health, because California, I believe, is one of the only states that I know, that I've heard about, that provides the opportunity for healthcare organizations to receive a timely death file back to then adjudicate vital status in an electronic healthcare record, for example, which is very important to get our statistics right. And I'll just give you a little insight into that. I used UC Rex last week before another talk on data quality, and I did a query for, I knew I was biasing it, of course, want to make a point. But I selected non-deceased individuals over 85 years of age in our electronic healthcare record system. And the number of records, now realize across our system we have 14 million records in the UC records, so that doesn't mean they're useful records, okay? 1.8 million. Now, the census 2010 showed 600,000 in California totally. So either we have really good medicine or DIRTA, really bad DIRTA. So, of course, I used the extreme, right? We're going to have people that are 150 years old and things like that because there's no opportunity to clean the data with this kind. So we need to partner. We really do. You have data that is useful to us, and we have data that's useful to you. And we can partner to make that much better in a privacy-preserving way. There are ways to do this. So that's my sort of shout out to CDPH about that. That, I think, is transformative. And the UC health system is taking advantage of that. And again, I learned a lot about record linkage through that process. But anyway, so that's just an example of the kind of thing that I think could happen with this partnership. If there's a desire, willingness to do that. So the PScanner network is there. We're actually formulating a sort of an idea. The PScanner California, nobody knows what PScanner really means. And I'm tired of trying to remember the acronym anyway. So we came up with a name of California Health Data Network. So CHDN, and we're just kind of thinking about, do we do something kind of like California Health Information Exchange, or CAHI did, which is create a nonprofit and to advocate for people to do things, to put it in this common data model. And then you decide whether you want to connect to the network for specific reasons or not. But the fact that you put your data in there at least deals with the IT information part, and it doesn't become part of the obstacles in the way. So anyway, if anybody's interested in in that kind of idea, we are all ears. The last thing I'll mention also is Medi-Cal, or DHCS, through Dr. Scott, is participating in PScanner. And they collect, with PScanner investigators, sought funding from the California Healthcare Foundation, and are experimenting with creating an OMOP, basically a common data model, kind of a view of the data, and this idea that we would be able to join data sets, link them in a privacy-preserving way. Again, with appropriate, you can't just step up to the terminal and start using the system. You have to have the appropriate process for getting access, and of course you saw the controls both at the query level locally as well as the result level. So this is not something that would happen automatically unless that was the desire of those involved. And I think there are a fair number of queries that would need those controls, and some that would be sort of aggregate counts. And we see that kind of thing happening. I hope it would be a voluntary sort of partnership. So I will stop there.